Welcome. I hope you're having a wonderful day. Now we are moving on to the topic of sexual dysfunction. And more specifically for males, we're going to talk about erectile dysfunction. Erectile dysfunction is defined as the inability to achieve or maintain an erection sufficient for satisfactory sexual performance. Erectile dysfunction is a common problem, and at least 12 million men in the U.S. 40 to 79 years of age have erectile dysfunction. The physiology of normal penile erection is complex and involves higher brain function, sympathetic and parasympathetic nervous system pathways, and perhaps most importantly, a healthy penile vascular system. So with sexual stimulation, the parasympathetic impulses via the cavernosal nervous system causes a release of nitric oxide, which in turn increases intracellular cGMP and vascular smooth muscle within the corpus cavernosa. This causes vasodilation of the arteries and venules of the corpus cavernosa, allowing it to fill with blood. As the cavernosal sinuses fill with blood, they compress the veins that drain these spaces, preventing outflow of blood. And then elongation and rigidity of the penis occurs, and once orgasm occurs, there's activation of the sympathetic nervous system, leading to emptying of the corpus cavernosum. Any impairment of the normal physiology of erection can lead to erectile dysfunction. This includes damage to the nervous system, as may occur with diabetes or prostate surgery, vascular damage due to atherosclerosis, or the effects of drugs and other agents that impair both neural and vascular function, such as overuse of alcohol. In particular, erectile dysfunction is commonly associated with cardiovascular disease and may be an early indicator of vascular disease. Many drugs are associated with causing erectile dysfunction. Some of the more commonly used agents are listed on this slide. If drug-related erectile dysfunction is suspected, other therapeutic options should be considered. If the suspect drug is necessary, addition of a PDE5 drug may be appropriate. The PDE5 drugs increase the normal response of the penile vasculature to nitric oxide. They do so by inhibiting phosphodiesterase 5, the enzyme that breaks down intracellular cGMP. Smooth muscle relaxation leads to vasodilation. More vasodilation means increased blood flow to the affected glands, leading to an erection. The PDE5 drugs can overcome erectile dysfunction that results from psychogenic causes, such as stress and anxiety, or neural damage, as long as the smooth muscle in the penile vasculature is at least partially preserved. Sexual stimulation is still necessary to initiate an erection. There are 4 phosphodiesterase 5 inhibitors. So sildenafil was the first one that was developed in 1998, and it was actually discovered as a potential treatment option for angina. Then we have tadalafil, vardenafil, and avanafil. All are used for erectile dysfunction. Sildenafil and tadalafil treat pulmonary hypertension under different trade names. All have a limit of 1 dose per day. side effects associated with PDE5 inhibitors include flushing, headache, and dyspepsia are the most common, but also may include dizziness, nasal congestion, hypotension, tachycardia, palpitations, and impaired vision. And then in a small number of cases, prolonged erections or priapism may occur, which is considered a medical emergency. Here is a table comparing the 4 PDE5 inhibitors. Sources vary with this information. I tried to use up-to-date as much as possible. Avanafil has the shortest onset. Sildenafil, vardenafil, and tadalafil should be taken 60 minutes before sexual activity, although the onset of action may sometimes be more rapid than 60 minutes. Avanafil and the oral disintegrating tablet, the ODT vardenafil, are more rapid acting and can be taken 30 minutes before sexual activity, but Avanafil is advertised for 15 minutes. The duration of action for sildenafil, vardenafil, and avanafil is about 4 to 5 hours, although some effect may persist for 8 to 12 hours for men with mild to moderate erectile dysfunction, and in contrast, tadalafil is effective for up to 36 hours after dosing. And if you notice on this chart, tadalafil has an immediate onset formulation and a daily formulation that's used for BPH and can be used for erectile dysfunction. Nitrates are contraindicated with all available PDE5 inhibitors. The onset and duration of action separates one PDE5 inhibitor from another, as we saw from the last slide. Sildenafil and vardenafil must be taken on an empty stomach because high-fat meals and alcohol may delay absorption. But food does not interfere with the absorption of tadalafil, avanafil, or the oral disintegrating tablet vardenafil. MI and sudden death have been described with and after intercourse, both in men who have taken and have not taken a PDE5 inhibitor. Thus, the relation to the drug is uncertain. Stimulation is still needed for erection. All are metabolized by CYP3A4, and so strong inhibitors of CYP3A4, which might be protease inhibitors, the HIV drugs, systemic azole antifungals, certain macrolide antibiotics, they can all elevate the PDE5 inhibitor concentrations. Co-administration with alpha-1 blockers may cause symptomatic hypotension. So if co-administered, first stabilize the patient on the alpha-1 blocker prior to starting a PDE5 inhibitor at a reduced dose. And tamsulosin and silodosin may be better tolerated than other alpha-1 blockers. Avanafil is the newest PDE5 inhibitor. The patient can take 100 to 200 milligrams as early as 15 minutes before sexual activity. Those two doses are the ones that work in 15 minutes. If a 50 milligram dose is used, it should be taken 30 minutes prior to sexual activity. And a reduced dose of 50 milligrams is recommended if co-administered with an alpha-1 blocker or moderate inhibitor of CYP3A4. With this one, absorption is not significantly impacted by food unless it's a very high-fat meal, and it's contraindicated for use in patients with a creatinine clearance less than 30, or the patients on hemodialysis, and in those with severe liver disease. The initial dose of sildenafil should be 50 milligrams, and it should be reduced to 25 milligrams if side effects occur. If, on the other hand, it's well tolerated, but the erectile response is not fully satisfactory, the dose can be increased to 100 milligrams. The duration of action is approximately 4 hours. A reduced dose of 25 milligrams is recommended if co-administered with a strong inhibitor of CYP3A4 or an alpha-1 blocker, and in patients with renal failure or moderate hepatic failure. Sildenafil occasionally causes blue vision in men. The PDE5 inhibitor in sildenafil cross-reacts with the PDE6 inhibitor, which is present in the retina and plays a role in color vision. So blue vision's been reported in approximately 3% of sildenafil treated men. It lasts 2 to 3 hours and disappears spontaneously. Blue vision has not been reported with vardenafil, tadalafil, or avanafil. Tadalafil works up to 36 hours. The dose for as-needed treatment is 10 to 20 milligrams about 60 minutes before sexual activity, and 10 milligrams should not be taken more than once every 72 hours if co-administered with a strong inhibitor of CYP3A4. Dose adjustment is needed for renal or hepatic impairment. Then there's the daily treatment. So a daily low-dose tadalafil administration eliminates the concern about onset and duration of action. And lower doses of tadalafil, the 2.5 and 5 milligrams, are available for once daily administration. And this approach appears to be just as effective as taking higher doses on an as-needed basis. And daily tadalafil has also been approved for treatment of lower urinary tract symptoms due to benign prostatic hyperplasia. So men that have both ED and benign prostatic hypertrophy may benefit from the convenience of taking one medication to treat both conditions. For the daily treatment, it needs to be reduced to 2.5 milligrams once daily if co-administered with a strong inhibitor of CYP3A4 or an alpha-1 blocker. And then for either doses, administration with a high-fat meal does not appear to alter absorption. The last PDE5 inhibitor to discuss is vardenafil, and the dose of this one is 10 to 20 milligrams on an empty stomach about 60 minutes before sexual activity. And for patients that are 65 years or old, use 5 milligrams initially. There is an oral disintegrating tablet that's under the brand name Staxin, and that may be taken on an empty stomach at 10 milligrams. And then administration with a high-fat meal may delay absorption. That's why we have it say take it on an empty stomach. And a reduced dose is recommended if co-administered with a strong inhibitor of CYP3A4 or an alpha-1 blocker. And dose adjustment may be needed for moderate hepatic impairment. PDE5 inhibitors should be avoided alongside other drugs which can precipitate dangerously low blood pressure levels, such as vasodilators, calcium channel blockers, and other hypotensive agents. And PDE5 inhibitors should be avoided, or at the very least, given at lower doses in patients with hepatic or renal impairment. They should not be taken alongside nitrates such as nitroglycerin, isosorbide mononitrate, isosorbide dinitrate, sodium nitroprusside, and alkyl nitrates, known colloquially as poppers. And then levels of PDE5 inhibitors are increased by CYP450 inhibitors such as amiodarone, erythromycin, cimetidine, diltiazem, protease inhibitors, and fluconazole. The onset of several PDE5 inhibitors is delayed when taken with food. And one thing I didn't discuss was that you can't write this for 1 tablet per day and give them 30 tablets. Typically, insurance will only pay for 9 tablets per month. Thank you. I hope you have a great rest of your day.